Welcome to UMDF's Ask the Mito Doc monthly webcast. Tonight we will embark on a special format, coffee and conversation with 7 clinicians joining us in 4 breakout rooms. We have Dr. Scalia in breakout 1, Dr. Marava Kosiks and Dr. El Sharqui in room 2, Dr. Grotman and Dr. Lashman in room 3, and Dr. Ganetsky and Dr. Vernon in room 4. Each room will have our very own ambassadors moderating discussion around the themes of Mito 101 and patient rights and responsibilities. Please do not enter the rooms until we instruct you to do so. Our Ask the Mito Doc webcasts are made possible through the generosity of sponsors, so we ask that you join us in thanking the Edith Trees Charitable Trust and UCB for their ongoing support. Okay, let's get started. You can now go ahead and proceed to your desired breakout room, and if you need any help, just let Jessica know and she can help you out. Enjoy.
On Mila and Elhan Plus.
Thank you. For those of you that didn't hear that little bleep, I just turned the recording on, even though I have notes all over. Press record, Margaret, press record. I forgot. So I finally have done it. So we cut off a little bit of Dr. Grotman's introduction. And so next I'd like to introduce Dr. Kumari Lachman from the University of Miami. Do you want to tell us a little bit about you, Dr. Lachman?
Yes, of course. Hi, everyone. My name is Kumari. I have started a mitochondrial genetics clinic at the U of M in Miami, basically to address the needs of the patients in that region. We hadn't had a clinic that could see adult and pediatric patients. I'm also highly interested in only mitochondrial disease. I am a clinical geneticist by training, but most of my time is spent in the research lab with mitochondrial, anything to do with mitochondrial disease testing or analysis. And I work under Dr. Carlos Morea's Mito lab. So I'm happy to be here and to help you in any manner that I can.
Thank you, Dr. Lachman. Next, I'd like to introduce our 2 ambassadors that are going to be helping us lead discussion today. Drew, would you like to introduce yourself?
Sure. Hi, my name is Drew. I am 29 years old. I have a clinical diagnosis, not a genetically confirmed one. I use they, she pronouns, and I live in Massachusetts.
Thank you, Drew. Jackie.
Hi, my name is Jackie Light. I have a 19-year-old son who has KSS.
So now I'd like to get started. I want to do a little housekeeping. Oh, hang on, slides to advance, which for whatever reason I have to move this to be able to advance them. So some of the topics that we're going to be including would be like obtaining insurance, thinking about insurance, how to deal with insurance, rights pertaining to your medical records, and then dealing with different kinds of case managers. This list is not exhaustive. If there's something else that you all want to talk about, raise your hand and ask. That's the point of this, is to have a casual conversation surrounding these patient rights and responsibility kind of topics. In order to ask a question, though, I do ask that you utilize the hand raising feature, which you can find at the bottom of your screen under reactions. You see the little face with a little plus on his head. That's reactions, and then there's a raise hand option once you click on reaction. So I encourage you to use that in order to ask your questions. But the ambassadors may get us started on a topic if y'all don't have any questions yet. So I am going to turn the floor over to our ambassadors. I'm going to pop some things into the chat feature here right in a second. But I will, I guess I'll get started with you, Drew. Do you have a topic that you'd like to introduce?
I guess with the rights pertaining to medical records, that's definitely an interesting one, especially with like the Cures Act that states like that when results are available, you are entitled to them as the patient. I guess what's the best way to go about making sure that that is happening with your doctor, without just like making it awkward or weird, like how to bring it up to your doctor if you're not getting results when they're available.
I think this brings up something important that I have as a listed question. How do patients ask for things? What is the best way? Like if Drew has had a test result and she doesn't have the answer to it, what's the best way to get those answers? What do you think about my chart or similar technologies, or calling the office, put it in writing? What is the preferred thing? And this could go for either Dr. Grotman or Dr. Latchman.
I can answer, what we generally do. And it all depends on the patient's comfort level. So we do have, portals where you can communicate directly with me. And so usually when I have my clinics, I always, try to address, are you comfortable? Do you know how to use it? Is this the best method during the visit? Some people are not so comfortable, and then I need to give alternatives. Like if you need to contact me because you could not get in touch with someone in the office, of course, they always need to get the basic information from the office. This is how you contact for medical records, etc. But I'm the backup person to contact if you cannot reach the office. I may have to even share my email. But generally during the visits, we try to discuss, what are the things that you need and what is the time limit for you to get them? And if you don't get them, how can you reach me so that I can move the process along?
So I actually hate the portal. So I'm old fashioned. Like I have a lot of the patients who just email me directly, or just I call them, or they call me. But everything is available in the portal. But with regard to genetic testing and counseling, we have a full-time genetic counselor dedicated to the Mito clinic, and all our other neurometabolic disorders are seen by her as well. So she'll go through the whole process of testing, insurance, what it covers, what it doesn't. And then when the test results come back, usually does like a PowerPoint for that specific patient that they can take with them. On the notes, we include who the patient saw and how they contact us for questions. And we generally have, like a care plan that the patient is involved with in the decision-making process. And we write that in the note, like we offered the following options and the patient, decided to do this. If we have any referrals, we give the information how to get those scheduled. And I usually say, if it's been 2 weeks and you haven't heard back from, for example, radiology, like let me know so I can bug somebody. So I think that I don't think my patients have a hard time getting me. Like I even answer them when I'm, not on the weekends, when I'm like overseas, when I'm on an airplane and I have Wi-Fi. So yeah, we try to make ourselves accessible. The other thing that we've done is we set up just a like neurogenetics call schedule, because at night when some of our like NELAS patients come in, the fellows often didn't know who to call. Is it neurology? Is it genetics? And so we have 3 of us who are neurogeneticists, and we're on call, each 4 months out of the year. And so the fellow and anyone else can call that person directly. And it's mainly just for the Mito patients, because we realize that in the busy neurology service, it's hard for them to give the time. So we do have that dedicated call service that at this point is mostly Mito, but we do have some urea cycle and other metabolic patients who also we take care of when the fellow calls us for those.
Go ahead.
Speaking of care plans, that kind of brings up another question of if there's something that's not accurate in your record or your care plan, what's the best way to go about remedying that?
Are you
That's
asking the
good.
doctors or the patients?
The doctors, like,
Oh, well, I mean, if someone points it out to me, I'll redo a note and make a note why I had to correct it. I mean, they don't like you to change notes unless it's something significant. So, for example, if it's a child and it said he goes to camp on Tuesdays and Thursdays, and I wrote Tuesday and Wednesday, I don't think that would be, significant enough change, although I have had parents request that. But, we try to update medications and other important things and try not to just do like a carry forward from another note to make sure that there's accuracy. But patients can request if they think that the note's inaccurate, at least at our institution. And, if it's medically important, we'll change the note and we can modify the notes. We just have to say why we're doing it.
Yeah, I agree with Dr. Groupman. It's the same process. I mean, I use the portal a lot, and I always let my patients know they have my cell phone, just like I think you mentioned. Text me if it's an absolute emergency, or use the portal, or second, use the email. But the portal is used by me for exactly those things, because I always encourage them, go and read the note, go and look at things. If you see something is not right, let me know. And yeah, we can addendum, or we can give a valid reason why we need to fix something.
what if
And
you're not
sometimes,
sure which
go
one of
ahead.
your providers entered it?
Tell me again, you said something about which one of the providers?
Yeah, like if you see something in your chart that is not accurate, but it doesn't say who it was entered by.
Usually at our institution, everyone has to write who is on the note. We have a heading that says, Dr. So-and-so is present with genetics counselor so-and-so, with nurse practitioner so-and-so. I think that's a legality.
Yeah.
I asked, just building off of when Dr. Groban, when you were talking about having like the on-call list. Again, a lot of us, we travel in order to get our care. We may end up at a different emergency room, not at your hospital. What would you advise then?
For our patients who travel elsewhere. So
Or
they all have an emergency letter to bring to the ED. So there are certain categories on the emergency letter. So one is for if they show up in another emergency room, just a little blurb about them and what they should and shouldn't get, and there's a number to call. The other is for any either elective or emergency surgeries. And, it took a while, but our anesthesiologists are really good, and they'll call us and say, such and such is scheduled to have ear tubes put in, what precautions should we take? And, they didn't used to do that years ago, and then we get mad and yell at them. We'd say, didn't you see the letter that the patient or the parent showed to you? And they hadn't, or and they ignored it. But I think it's the communication. I know a few years ago, they didn't communicate with us that they were getting rid of normal saline for surgical procedures and replacing it with lactated ringers. And I said, oh, okay. So then I had to go into like all of my patients and put that in as an allergy, just so that they, it's not a true allergy, but that was a way to flag it so that they wouldn't get it. As first line of defense, but of course we still have to tell them. Like today, somebody sent me an email about a stable mitochondrial patient who's getting some Botox for the first time, but they're doing multiple areas, so they want to do it under anesthesia. So they asked for any precautions. So I think just establishing the communication with the other people who may be seeing the patients besides you, and then having the emergency letters, and they can always call. Like I've had some of my patients show up at Hopkins, or I had one in North Carolina, and they just called over.
I have a question surrounding emergencies also. So if your specialist is in another state, and you're either going to be traveling or going to be in your own local area. Is there benefit to reaching out to the, say you were a meal loss patient and you needed L-arginine? Is there a reason to reach out to your local emergency room and let them know that there is a potential that you might come in and these are the things that you might be coming in for? And if so, how do you go about that?
I can try to answer, based on what we do here in Florida. So first, every patient has to have the letter, right? So the emergency guidance letter, and there is direction at the bottom. If please call me. I'm the mito specialist for this patient. If this patient is in the ER, but if the patient knows that they're traveling, say, I don't know, I'm gonna just say a state, random state Z, that doesn't necessarily have a ER that is attached to an academic center or anything like that, I usually have to give some advice to the patient that you're going to need IV arginine in the worst case scenario. How can we make sure that you have it? You may not have it in that area because I cannot convince that hospital to get it for you. But I need you to realize that if that happens, you need to go to this other center because I'm going to have to contact the bigger center where I know I have a better chance that they're actually going to have it, right? Because not all hospitals have certain things. Mm-hmm. So, and that only goes, of course, for that specific disorder, because many of the mito patients, they need certain testing, but they don't necessarily have a specific kind of treatment, But that does take work, and I think I missed the second part. What was the second question?
It was really just like, is there benefit for our families to go there in advance and introduce themselves and say, hey, I have this disorder that you may not know about. Here's a little information. If I come, can you put this in my record that I might be coming for this reason? I know that one of the local hospitals here came up with a system where they would flag the mito patients and include things like lactated ringers and things just on a little red box, so that when they presented in the emergency room, there isn't a mito specialist in this. Well, there is now, but there wasn't at that time. Yeah. And so they came up with that system to be able to alert folks.
Yeah, I mean, so if it's one of our patients who's coming to our ED and the parent calls, we let our fellow on call know, and then the fellow tells our ED. So that's within our system. If they show up elsewhere, usually they've seen the letter and they call us. Now, if we know ahead of time, so a lot of times with my fragile patients, the family will say, I'm going out of town, who is a mito specialist there. So usually I've made some connection ahead of time with, patients with whom I'm afraid something could happen, either related to the travel, like if they're going to Florida in the summer and they could get dehydrated. So I've already sort of made a prior connection, but they still take the same emergency letter. For people who go out of town and don't tell us, and then they like randomly end up in an ED, it's hard because sometimes a community hospital won't have arginine and they're not going to get it because, they're not going to just get it for one person if they never use it. So then we try to look for, like a more tertiary medical center, or come up with a workaround if we can. If they're really sick, then they'll have to go to, a bigger hospital.
Okay, that's very helpful. I just wanted to direct everyone's attention to the chat feature. You should be able to see a list of patient rights and responsibilities that everyone could expect. Some of the ones, when I was reviewing this in preparation for today, one of the topics that is important because it comes up a lot is that the patient has the right to be believed. And we often find that, I would say I asked the question once in the adult virtual support group, and about 75% of the patients raised their hand that at one time or another, they were not believed by their medical professionals. And this included people that even had a mito doc. How does a person address that? And what can they do to either, if it says in their record that they're, you know, they have psychosomatic symptoms, how do they get that kind of thing removed?
So I have a personal experience, and my daughter had severe food allergies when she was an infant. Actually, she had them until she was 18. And so, you know, she had some feeding issues and vomiting and all kinds of things going on. And I wasn't believed by my pediatrician, and I'm in the medical field. So, you know, I switched doctors, but I don't recommend this. I basically fed her in his office so he could see that it wasn't just mild reflux, and she just had like projectile vomiting all over the place. And then he said, okay, yeah, I think we should, you know, get a nuclear medicine study and do some other workup. So that was the extreme. I think that patients definitely have a right to be believed. And I know for physicians who aren't familiar with Mito and they read this litany of symptoms and they don't know how to put them together, you know, it's easy for them to say the patient is, you know, functional or has psychosomatic symptoms and just kind of give up and not want to treat them. I think if possible in that institution, if there is a Mito person, because sometimes people get scheduled and they don't end up with the right people. So I think that if that's the case, it's kind of futile to continue that clinical encounter because you're going to have distrust and all kinds of things that just redirect them to the right person is what we try to do. Because we've had people end up in the wrong places. You know, you get a Mito patient ends up in headache clinic and they're not a typical, you know, migrainer, which the headache clinic sees and they infuse them and everyone gets better. But that's what we do here.
What if it's like in an admission setting or an emergency room setting where it's not an outpatient provider where you have the option of not continuing the relationship?
I mean, they always call neuro for everything in the ED. So their neurology fellow would get called, and then if it said Mito on the chart, they would call whoever of us is on neurogenetics call, and we would try to sort it out. But that's just us, so I don't know how it works.
Yeah, I think I can add a little bit as well as, you know, I've had situations where the patients are in the ER and even though they showed the letter, the ER physician says, okay, that's what, you know, I understand the diagnosis. This is what I'm going to do anyways. And then, you know, on the bottom has their phone number and they didn't call us. So the patient called. I mean, it's extreme, but then we had to, you know, answer the call, make sure that we spoke with the physician at that moment. And even though the patient may not see that ER physician again or go back there, the opportunity to sort of teach them, we have to use it at that moment, you know, okay, follow the letter, this is the reason, you know, everything that's written there and what the patient is telling you is correct. I'm verifying it for you now. And sometimes that works, but it is not always, you know, possible sometimes for them to reach me when they are in the ER because maybe I'm not on call. So they will call the fellows and then the fellows will call me and say, your patient is in the ER, there's a problem. Do you want to speak with them or do you want us to handle it? And, you know, we try to address, like, do I need to get involved or can the fellow handle it? Or sometimes I have had to get involved and actually call the ER, you know, doctor, but it is unfortunate. Many patients are not believed, not only mitochondrial disease patients. It's so unfortunate.
Yeah.
And many of the patients that come to us in genetics or mitochondrial clinics, they have gone through the ringer. They have seen so many specialists. They have gone to big centers, small centers. They have been discounted, belittled. And so, you know, it's a widespread negative experience. All we can do is try to give them hope, you know, whenever they do get to us, that you are in the right place now and we will do what we can, you know, to help you.
I have something just to piggyback off of that, if I can. Just as a patient experience myself, I have an ER letter from a Mito doc that I met through UMDF, and he's in a different state, and I'm in a went in for simple procedure like a colonoscopy, did the pre-op thing that you do a couple days before. I gave him the letter, and then I said, "You've got to read my protocol, make sure you're on top of this." I show up the day for my colonoscopy, and the anesthesiologist hasn't read my letter. Nobody's read the letter. It's just terrible. And so that's the frustration. And I know I'm in a small part of the country in Alabama, and there's no specialist here, but they didn't even bother reading my letter when I went days in advance. And then the morning of the procedure, I'm having a panic attack because they don't do and communicate and have already read up on my rare disease. So that's part of just one of my little frustrations with when, even though I have an ER letter from my doctor, nobody bothered to call them, see how important little things are just for small procedures as a routine colonoscopy.
Unfortunately, that's happened with some of my patients. And Kumari, you can, since you see adults and peds, I only see a few adult patients, small percent. It seems to be that scenario more with the adult providers than peds. I think we've scared the pediatric providers that they'll call us for everything, but I think the adults are a little bit more cavalier in their thinking. And I think there's also miscommunication that they think that a lot of these metabolic and mito disorders are childhood onset diseases, that they only occur in children. And so they'll question, especially if an adult has a later presentation, that it can't be because, you're supposed to have had it when you were a child. If it's genetic, they associate that as genetic, symptoms all present at birth or early childhood. And so I think, we probably haven't done as good a job educating the adult providers as we have with pediatric providers and ourselves. I mean, we're always, educating ourselves at meetings, but we're not necessarily educating the frontline folks who are seeing you before you get to us, if you get to us.
Right. I've always been, and I'm an adult, and as far as I wish that I could be part of like those grand rounds and like just use me as a training tool to let me, be an advocate somehow for the communication process. I wish there was something that I knew how to help the doctors, just to make it when people come in with these ER letters that are, certain protocols and they don't know what to do with it and they don't. So, but thank you. Yes.
Well, in the old days when I trained in neurology, we had to do a year of adult. We always had grand rounds where they brought in a patient and they examined the patient in front of us, and they had interesting findings, and then everyone would try to figure out what they had. Sometimes the diagnosis was known and they were just, trying to see if they could get a consensus from the trainees mainly. But sometimes it truly wasn't known. But I mean, those days are over. We're not doing that, but it was very useful. I really learned a lot. And I think that the patients also got benefit from it because they got other perspectives, like their doctor brought them as an unknown and someone else in the audience had an idea that no one else had thought of. So I think, I don't know if that model exists anywhere, but.
Oh, wow.
Thank you. I don't know if this will help coming more from the case management perspective and the patient rights perspective. So I'm kind of switching hats at the moment. But I think sometimes we do forget in terms of patient rights, we have that right to speak up. So Mary Holly, like what you're saying, if you can ask to speak to the anesthesiologist, and I think it's so hard for a lot of us to advocate and to really make sure that we are understanding. But as patients, we have every right to make sure we speak to a surgeon, we speak to the anesthesiologist, that we are comfortable with everything that's going on before it happens. And I think we often kind of back off and think we can't, but No, that is one of our rights. And if you don't understand it and you have a question, you keep going with your questions until you understand it and they're on the same page.
Okay.
You can go back for another pre-op visit. I mean, I had to decide about a surgery I had, and I had done some reading and in the literature and all that. And I had a bunch of questions and I wasn't sure. So I made an appointment just to, he didn't examine me or anything. It was just to kind of discuss and for me to make a decision whether to proceed or not. Because I didn't feel like I had enough information. The visit was rushed and I came back. My husband came too, so he would understand, what type of post-operative care would be needed. So you can do that, whether it's with the physician or someone on the surgical team. If you don't have to sign on the dotted line till you understand, and you can bring a caregiver with you, especially if that person has to be involved in the post-operative care. Like, they need to know, what to expect. So you can do that.
I did think also, Mary, I understand, because I think from your perspective, there's still some barriers between the communication of patients and physicians, and we need to break down those barriers, because one of the things that I try to empower my patients with is, they do not need to agree with anything, not even what I'm telling them. They need to feel comfortable, right? That they feel in their gut, even if they don't know medicine, that they trust what I'm telling them, that I've showed them enough literature. And so, unfortunately, maybe you may not have had a physician or some, provider that took the time to sort of guide you in that way. Always ask questions, make sure that you feel comfortable before moving forward. And but what you say, it is widespread as well. And you learn from that experience, and it was a negative experience, of course. Now, in a way, hopefully you find a way to share that so others will realize they have a right as well, because as physicians, it's easy for me to feel like I have a right and ask things, right? And it's very easy for me we're trained, no? And so when I see my patients, I remind them that you have to advocate for yourself or your child or your brother or your sister, because I'm not always going to be there, and at the same time, not everyone is going to really listen. You have to have that sort of energy and that fight in you, right?
Right.
I think it's important that we acknowledge that there's a very delicate balancing act as a patient of how to advocate for yourself, but not so hard that you get labeled as difficult or defiant and disruptive, because I see that happen a lot, especially with female presenting patients, where they advocate and it backfires. There's also a very large, I just want to put it out there and acknowledge that there is a big discrepancy in care between patients with the genetically confirmed diagnosis and not. Unfortunately.
Yeah, it's almost like a discrimination, right? You have a gene or you don't have a gene. I don't really believe you because you don't have a gene, and things like that. So, I mean, that's challenging for the patient. The only hope I have is that they will keep looking for the right provider, who will actually be interested in helping them. And it's not always easy. As you know, every state doesn't have a mito specialist or someone who's highly interested in, mitochondrial conditions.
How do we get a case manager? I'm just the basic question. How do you get assigned a case manager? Do you request that through your insurance company or through the hospital itself, or how do you do that?
When we wrote this, we were really, I guess, thinking of case managers that might come through Medicaid, Medicare, or private insurance.
Yeah.
But the hospitals have case managers too, and it's all kind of different, and it's all kind of a lot. I don't really understand it, which is one of the reasons I wanted this topic to come up, so that I could have more of an understanding on how it works. how it would improve patient care. Is there a benefit for our families? Will it make things easier for them? For our adult patients in particular.
Do you want me to hit that for a second? I could probably speak to that a little bit. As a social worker, again, we often do case management, and I think it is something people don't realize. A lot of the insurances, both private, Medicare, and Medicaid, do have case managers. They don't often, although interestingly, I have seen with children, they do tend to reach out more. Like with Jared, they've sent out more to him. I have chronic medical conditions. I've never gotten a letter from a case manager saying, "Hi, can I help you?" Jared's gotten like several of them repeatedly. But you can call your insurance. Medicaid is actually usually pretty good about assigning a case manager. The private insurances have them too, and the ideal is that that person would actually step in. So, all that craziness of trying to get an MRI approved, the case manager can actually take over that for you. They can do the calls, they can get the approvals, they can kind of help coordinate the care. But again, sometimes you just have to know to ask for it. And if you're in a Mito clinic, they will usually have a social worker who can act at sometimes in that role.
Yeah, we have a social worker in our program, so we don't, because it's a pediatric hospital, we see some adults, but not that many. So most of our case management is focused on pediatric patients, but we'll start with our social worker to see. And then we do have a number of community organizations that advocate mainly for patients who don't have insurance. So we have in Maryland, we have the Rare and Expensive Medical Act. So, and usually Mito is one of the diagnoses. And so that helps pay for a lot of what we ask the patients to get, equipment and medications and things like that. And then there's a similar one in Virginia, and it services patients who are Spanish speaking. So like the Latino population, we don't have anything like that in DC because we service 3 states and they all have separate and different policies. So DC is hard. So we usually will go with the insurance case managers, but we start with social work or the local resources. We try to get everybody on the Rare and Expensive program. You can only qualify if you have Medicaid though. So they're for low income or patients who fall below, a certain income level, those two. Yeah.
I can only speak on my experience, but I have Massachusetts state Medicaid, and I know that I got assigned a case manager for the first time recently when my enteral and specialty infusion companies dropped their contract with my subplan of Medicaid, and the case manager was assigned to help with transition of care. But they only stay assigned until the specific task that they were assigned for is completed, and then they are off your case. And at least in Massachusetts, you can't request a case manager through your insurance. It's only during times of transition of care. So it might vary state to state.
Mm-hmm.
That's not surprising, just like the Medicaid waiver programs that are available to children are vastly different from one state to the next. So for a family, for an affected adult, and Jackie, you probably could talk to this in the best way. How would a person find a case manager outside of those 3 settings? We talked about hospital. Would they reach out to social workers that are in their community? What would be the best way?
I mean, it's hard because if you, and again, most of us don't, we're using a lot of our money towards our medical bills. But you can hire a personal case manager. They do exist. Somebody who that's what they would do is manage all of it for you, your insurance, your medical. They take you to where you need to go. They would kind of do all that piece. But again, that costs money, and insurance does not usually cover that. So usually the best way is to try to go through the insurance. private insurance, again, you'll probably get more from them. And as Drew pointed out, I mean, Medicaid is interesting because it's both state and federal, where Medicare is just federal. So again, kind of different what you can get. But I do think it's often start with a social worker. They're usually the best person to start with.
Yeah, in Miami, you know, we have a social worker, and we use her a lot for the adult patients to help guide them. So we usually prepare letters to, one is to present for like getting additional medical care. Like, for example, they have a rare, you know, Mito gene, and their prognosis is, you know, they're not going to be able to do X, Y, and Z. So the social worker will help them with the letter to apply for further medical care and resources like disabilities and things like that. That's one of the, you know, driving the drivers in my clinic for using the social worker is to help them get access to resources most of the time. And then they're kind of better set, you know, they're better positioned because now they have the right insurance, they have the cheaper medical care, Medicare or Medicaid usually. And we've had success with that. That's the angle I've been using. And I see that it's helping the patients, you know, the adult patients.
Also, usually on the state websites, there's a list of what services are available for Medicaid and Medicare patients. I know that recently I applied for like a Massachusetts rehabilitation services, and they have like one of the programs that they have is like to help manage care plans. So it would be worth, if you're interested in a case manager and you're not sure how to get in touch with a social worker, potentially checking out your state website to see if there are resources there.
I just want to let everyone know we're going to be getting a warning in a second that we need to go back into the main room. We might have a few more seconds to go before that warning comes. But I just thank you all for being open and this really engaging conversation about a topic I don't think we talk about enough. This is something that I can't think of a time when we've sat down and addressed these very specific things that are really impactful on our patient community. So I think both of our physicians, thank you so much for being willing to do this. It means a lot to our patient community that we'll have a resource like this for them, that they know that there are things that they can do. And to our ambassadors, Jackie and Drew, thank you for leading such interesting conversation.
So I really want to thank everyone. I don't know how everyone felt about your rooms. We really want to hear your feedback. But I know there was a lot of questions, and I know we couldn't get to everything, but it seemed like a very engaged group in group number one. So I don't know how everyone else did in your breakout rooms. I do want to let you know that we will have a resource document that our ambassadors worked really hard on to pull together some resources that we will share with everyone along with the recordings. So I just wanted you to know that will be coming. It may take us a little while to get the recordings for each breakout room together, but we will be posting those on our Mito U. I really want to thank the doctors and the clinicians for being on tonight. I hope you found it interesting and engaging and not too overwhelming for this late at night. And also the ambassadors for helping us. This was actually this coffee and conversation breakout rooms was the idea of our ambassadors and Margaret Moore. And I think it was a really great opportunity to do something different for us, the Mito Doc. Maybe we'll do this once a year. We'll see how we've learned a lot. There was a lot of things we learned along the way here that we will remember and put into play. But I would really appreciate any feedback. Make sure you email us, and let us know if you have suggestions. And that's to the clinicians as well. If you feel like there'd be something that would work better for you, please let us know how you felt about the webcast tonight. So with that being said, I just want to thank you all, and we look forward to seeing you all again next month. I believe it is December. I could share the screen, and it will be a wrap up with our 2023 with our Mito doc. But yes, we will have 4 or 5 Mito docs on in December, and we look forward to seeing you all back then. Thank you, and have a good